give me a second. I'm gonna just start recording. Hello, everyone. Welcome to our Zoom meeting. Today we're gonna cover different topics. So Dr. Lee, give me a second, and our team will be leading the team. I'm gonna just give you the You're gonna present Leepy?
Yes, sir.
All right, I'm gonna make you the host and you're all set. Try it again.
Just a second. Good afternoon, everyone. My name is Dr. Leepy Paudel. I'm a research fellow with you guys. So I am an international medical graduate from Nepal Medical College, and I'm applying for neurology residency this year. So the topic for I'm the team leader of Forest Green 1. And I will be presenting on the topic dizziness in older adults with you guys. And there are other presenters from my team after me. So I'll be sharing my screen now. Is it visible? I guess I'm visible. So do let me know if it's not visible to you guys. So my topic is dizziness in older adults. I'm trying to set up slideshow. Just a second. So the agenda for today's meeting is definition of dizziness, classification, causes, diagnosis, and treatment. Dizziness is a disorder characterized by a sensation or feeling that the external world revolves around the patient or the patient is in space. Now, there are many terms used to define dizziness, like disequilibrium, lightheadedness, giddiness, fainting, pre-syncope, wooziness. So they all come to the same definition that the person is dizzy or the head is spinning or the person is feeling disconnected from the environment. The significance of today's presentation is that dizziness is a fairly common topic and we need to be aware of this so that we can help the elderly people around us. The prevalence of dizziness increases with age and it is more common in women than in men. The challenges for clinicians while treating dizziness is that precise classification is difficult and dizziness is a vague topic and it is usually the result of certain underlying conditions or dizziness for which the diagnosis can be difficult and specific therapies may not be available, and more than 50% elderly have multiple causes for dizziness. Now, acute dizziness is independent of age, and mostly it includes acute vestibular neuritis or cerebral ischemia or other cerebrovascular disorders. Chronic dizziness usually occurs if the dizziness lasts for more than 2 to 3 months and it has multifactorial etiology and it is more common in older adults. So it should be considered as a geriatric syndrome and require a multifactorial assessment. It is also associated with increased fear of falling or depressive symptoms or general functional disability. Now, since dizziness is a vast topic, I have tried to include the causes of dizziness from various systems of our body. I took this picture from a neurootology article, and I have provided the link here. So, peripheral vestibular causes for dizziness can be benign paroxysmal positional vertigo, vestibular neuritis, bilateral vestibular loss, late onset Meniere's disease or decompensation, labyrinthitis, occlusion of anterior vestibular artery. Central nervous system causes could include vestibular migraine, transient ischemic attack of vertebrobasilar artery, stroke, neurodegenerative disorders, nystagmus. The cardiovascular causes could include arrhythmia, postural hypotension, congestive heart failure, heart valve failure, And we all know that there are many medications that can result in dizziness, like antihypertensives, benzodiazepines, hypnotics, anxiolytics, and antiepileptics. Presbystasis is another balance disorder which can result in dizziness. And some other causes for dizziness can include primary and secondary neoplasms, vertigo, psychiatric conditions, musculoskeletal system disorders, proprioception, and somatosensory disorders. Now, coming to benign paroxysmal positional vertigo, or BPPV, it is an episodic inner ear disorder. So there are tiny crystals in our inner ear known as otoconia, which detect linear movement, horizontal and vertical movements of the head, and semicircular canals detect the angular movement. Now, when this otoconia are displaced or dislodged, it can result in vertigo. So this is aggravated by changes in head position, like rolling over, gazing up, gazing down. It is sudden onset and usually results from changes in endolymphatic pressure during head movements resulting from the dislodged otoconia. We also should be able to differentiate the dizziness caused by BPPV and Meniere's disease. So some difference, I have included differences here. Like BPPV is the dizziness which has the signs and symptoms like nausea, vomiting, vertigo, rhythmic eye movements, and loss of balance. In Meniere's disease, there's classic triad of symptoms like fluctuating one-sided hearing loss, tinnitus, and vertigo. Now, BPPV has certain short spells, and it is self-limiting, whereas Meniere's disease can last from 20 minutes to 4 hours, and episodes occurs in clusters with long periods of remission. The potential triggers for BPPV can be a loosening of the calcium carbonate crystals in the inner ear, which can occur due to head injury, surgery, migraine, certain viruses, and gentamicin toxicity, which is rare, but it can occur. Whereas the causes for Meniere's disease is vast, like the exact cause is not known, but it involves increased pressure in the inner ear, and so which can occur by head injury, ear infections, allergies, stress, smoking, alcohol, and certain medications. Now, the treatment for BPPV is Epley's maneuver, and Meniere's disease, it is usually treated by medications, lifestyle changes, or hearing aid. We also should be able to differentiate pre-syncope or postprandial hypertension or disequilibrium. Pre-syncope usually results from cardiovascular problems causing brain hypoperfusion through postural hypotension. Now, the definition of postural hypotension is that there should be a drop in systolic arterial blood pressure of 10 millimeter of mercury after standing up from supine position. Sorry, systolic blood pressure of 20 millimeter of mercury and diastolic of 10 millimeter of mercury after standing from supine position. But this is not usually common in older adults because older people commonly describe dizziness on standing from supine position without any orthostatic changes in blood pressure. But we have to be aware that pre-syncope is a sign of decreased cerebral perfusion. Now, dizziness can occur by postprandial hypertension, which is defined as decrease in systolic blood pressure of more than 20 millimeter of mercury in a standing or sitting position within 1 to 2 hours of eating a meal. Now, this equilibrium results from visual or proprioception abnormalities, which also has many causes. So we need to be able to diagnose the underlying cause. Now, there is another type of dizziness, which is known as mixed type of dizziness. It is usually the most common type reported by older adults. It likely results from combination of various diseases like vestibular or central nervous system or visual or proprioceptive symptoms. And systemic disorders like anemia, heart failure, diabetes mellitus, hypothyroidism can also contribute to instability or dizziness. Also, we also have to put as a differential, like carotid sinus hypersensitivity and carotid sinus syndrome should also be kept as a differential. I have also provided a picture here. I took this picture from the internet and I have provided the link. So this picture also shows localized oxidative stress process, which damages the cerebral vasculature and has promoted neurodegenerative alterations in the brain tissue by reactive oxidation species. Now, this microvascular endothelial dysfunction has resulted in cerebral autoregulation. So the role of the cerebral autoregulation would be to maintain adequate balance if the blood pressure drops. So this particular thing is damaged, which leads to orthostatic hypotension, postural lightheadedness, and imbalance. So older patients, when they have dizziness, the characteristics include that it usually resolves within days to several months. They are usually chronic or recurrent symptoms, and they have multifactor etiology. They are commonly associated with postural hypertension, anxiety, depression, and use of 5 or more medications. So they should be reviewed as a geriatric syndrome that require multifactorial assessment and intervention. Chronic dizziness is associated with risk factors like angina, myocardial infarction, stroke, arthritis, depressive symptoms, impaired hearing, or use of medications. So when we are treating a patient with dizziness, the most important part comes in history taking. We have to check the patient and allow them to describe the condition in their own words. And we need to ask if the dizziness is characterized by any of these 3 sensations like spinning, imbalance, unsteadiness, and whether there is positional effect on the symptoms, what are the frequency and duration of the symptoms, and if the symptoms peak at any specific time of the day. We also should ask what other symptoms are associated with dizziness. Specifically, we need to ask about hearing loss, ear fullness, diplopia, dysarthria, or tinnitus. We also should ask what medications the patient is taking, including any over-the-counter medications. We also should ask how the symptoms are affecting the patient's quality of life. And during physical examination, we need to take blood pressure. Blood pressure is a must. We need to take blood pressure both in supine position and standing position. We also should perform certain provocative tests of the vestibular system, like Dis-Hallpike maneuver, head thrust test, and side lying test. We should perform cardiac examinations, hearing test, vision test, observe for nystagmus, observe for balance and gait difficulties, perform cranial nerve test, perform Romberg's test, both eyes closed and eyes open, and certain tests like Valsalva maneuver, carotid sinus massage, fistula test, and caloric test can also be helpful occasionally. Now we need to be aware of this. We need to be aware of the warning signs in dizziness that include dizziness that occurs with change in vision or double vision or change in speech like slurring of speech, rapid irregular heartbeat or slow heartbeat, dizziness with convulsions, numbness or tingling, inability to move arms or legs, and ongoing vomiting, dizziness with chest pain, dizziness with shortness of breath, fever and neck stiffness, fainting or loss of consciousness. Now, there are many diagnostic tests for dizziness. First comes the lab test. In patients with chronic dizziness, we need to check hematocrit, glucose, electrolytes, renal function tests, vitamin B12, folic acid, and thyrotropin. And other tests can be included as per the requirements. Audiometry is helpful if cochlear symptoms are present. ECG should be conducted. Holter and event monitor can be used if you suspect arrhythmia. Tilt-table testing is done in selected patients with postural hypertension or syncope. Vestibular testing include electronystagmography or rotational chair testing. Sometimes neuroimaging like CT and MRI can also be done. MRI provides better resolution than CT for posterior fossa lesions. But while performing CT and MRI, we need to see if the patient actually requires the MRI or not. Now, since dizziness has many underlying conditions, the management of dizziness includes treatment of the underlying diseases. So if the dizziness is due to BPPV, we need to perform Epley's maneuver. Epley's maneuver is really helpful, and there are only rare cases where surgery may be required. Now, in case of Meniere's disease, we need to perform salt restriction, diuretics, vestibular suppressants may be helpful during acute attacks, or in severe cases, we might need surgery, including endolymphatic decompression or vestibular nerve resection and labyrinthectomy. Now, if the dizziness is caused by medications like aminoglycosides, diuretics, or NSAIDs, we need to discontinue the medication or reduce the doses or substitute the medication by something else. Now, in case of cerebral ischemia or orthostatic hypotension or various cardiac causes, we need to treat the specific cause, adjust the dose, and teach the patient to rise slowly from the sitting position or from lying down position. And we can also teach them about support stockings, physical therapy, occupational therapy, and medications like fludrocortisone or midodrine. And in cases of postprandial hypertension, frequent small meals should be taken, and we need to avoid exertion after meals. The patient should be taught about slow rising from sitting position and avoid antihypertensive drugs at or near mealtime. Now, this is the picture of Epley's maneuver. It is performed, so while performing this, the person should sit on a bed and turn the head 45 degrees to the left. Now, this is performed in case of left ear problem. So when the person is sitting at 45 degrees to the left, a pillow should be placed behind the person so that when the person is lying back, the pillow will be under the shoulders. Now the patient should lie back quickly with shoulders on the pillow and head should be reclined onto the bed. Now we need to wait for 30 seconds. Then the patient should turn the head 90 degrees to the right without raising it and wait again for 30 seconds. Then again, after 30 seconds, ask the patient to turn both the body and head to another 90 degrees to the right and wait for another 30 seconds. And then the person should be asked to sit up on the right side slowly. Now, this can be performed as many times as required, and there are only certain cases when this therapy doesn't work and the patient might need surgery. Now, vestibular suppressants, including antihistamines, provide effective symptomatic relief of vertigo, but they do not provide benefit in managing chronic dizziness or disequilibrium. Medication should also be used with caution because of its anticholinergic properties and potential adverse events in older adults. Long-term use should be avoided because it can suppress a central and vestibular adaptation and worsen or exacerbate dizziness. Similarly, benzodiazepines should not be used for long-term because they can cause memory impairment and also lead to dependence and addiction. Vestibular rehabilitation therapy is really good and it can help suppress symptoms in patients with peripheral and central vestibular causes of dizziness. Now, this includes various exercises like vestibulo-ocular reflex adaptation exercises or habituation exercises. Now, initially, the exercise can worsen the dizziness. But given with time, like weeks to months, movement-related dizziness improve, and it is likely because of central adaptation, and it can also improve the quality of life. Now, surgical treatment is also required in many cases, such as cerebellopontine angle tumors, and surgical excision should be reserved for disabling unilateral peripheral diseases that are unresponsive to medical therapy. Now, surgeons can perform ablative procedures like transmastoid labyrinthectomy or partial vestibular neurectomy for uncontrolled Meniere's disease. Non-ablative procedures can also be used like posterior canal occlusion. These non-ablative procedures provide benefit to those patients whose PPPV remains refractory to repeated attempts of canalith repositioning procedures. Now, other causes like vertebrobasilar ischemia or cerebral infarcts or hemorrhages can be treated with low-dose aspirin or clopidogrel or extended-release dipyridamole, aspirin, or rehabilitation. Tumors can be treated like acoustic neuroma can be treated with surgery. Parkinson's disease should be treated with its own medications and rehabilitation therapy. And peripheral neuropathy should be treated with, or vitamin B12 deficiency should be treated with nutritional therapy. So, like I said, all the underlying conditions should be treated to treat the cause of dizziness. Now that we have discussed about the causes of dizziness and the treatment and the evaluation, now I have put on a few cases which I will allow you guys to answer in the chat. So the case one involves a 72-year-old man who comes to the emergency department because he had sudden onset of vertigo, nausea, blurry vision, and left facial numbness while watching TV. Now, these symptoms lasted for a few minutes before resolving completely. He had two similar episodes over the previous 3 days. In his past history, he has hypertension, hyperlipidemia, and 50-pack-year history of cigarette smoking. On examination, the blood pressure is 153 by 90 millimeter of mercury, heart rate is 78 beats per minute, regular, respiration rate is 14 breaths per minute, oxygen saturation is 98% on room air, and the neurological and all other findings are normal. CT head is also normal. So which of the following would most likely establish the diagnosis for the patient? So the options are this Hall-Pike test, CT angiography of the head and neck, Doppler ultrasonography of the carotid arteries, and magnetic resonance imaging or MRI of the brain. I will give a few seconds for you to answer and I'll show you the correct answer. So the correct answer is CT angiography of the head and neck. When a patient presents with dizziness, it is important to determine whether he or she is referring to vertigo, syncope, disequilibrium, or a psychogenic incident. Patients should be asked to describe the symptoms without using the word dizzy. So, CT This patient reports episodic vertigo in addition to other neurological symptoms. Both his history of vascular risk factors and the localization of his symptoms to the brainstem are highly concerning for transient ischemic attack in the vertebrobasilar distribution. So patients who have TIA because of vertebrobasilar insufficiency commonly describe vertigo with associated brainstem symptoms such as diplopia, numbness, ataxia, nausea, vomiting, and weakness. Therefore, urgent imaging of vessels is indicated. CT angiography offers a quick, accurate method to assess for cerebrovascular stenosis. And if cerebrovascular stenosis is present, pharmacological neurointerventional management may be undertaken to prevent the progression into a posterior circulation stroke. So the next case is of a 75-year-old man who is brought to the emergency department because he had an episode in which he lost his consciousness. He recalls standing 45 minutes after dinner and suddenly feeling dizzy or lightheaded with generalized weakness. He next remembers being on the floor with incontinence of urine. 3 minutes had passed since he had last checked the clock. He immediately laid down and called 911. When the ambulance arrived, blood pressure was 90 by 60 millimeter of mercury. He does not recall any focal neurological symptoms. His past history includes hyperlipidemia, gout, and myocardial infarction 10 years back. So which of the following is the most likely diagnosis? Vasovagal syncope, generalized tonic-clonic seizure, postprandial hypertension, or basilar transient ischemic attack? So the correct answer is postprandial hypertension. Postprandial hypertension occurs 45 to 60 minutes after meal, especially if the meal is large in older adults with vascular disease. Now, the patient has symptoms consistent with cerebrovascular insufficiency because blood is shunted away from the brain and towards the mesenteric vessels to aid in digestion. Now, patients often describe feeling of lightheadedness or weakness during these episodes. In more severe cases, they may also experience syncope. Now, the patient should avoid large meals and instead eat smaller portions at more frequent intervals. And they should also avoid quick positional changes, especially after meals. Loss of consciousness generally has one of four etiologies like seizure, syncope, trauma, or psychogenic cause. This patient has a prodrome of dizziness that he describes as lightheadedness. So asking the patient whether he or she remembers what he or she remembers on awakening is always important. And this patient's recall indicates that he became aware quickly, suggesting he was not in a post-ictal state. Now, urinary incontinence is common with a seizure, but it can also occur with syncope. Generalized tonic-clonic seizure is less likely than postprandial hypertension in this case. So the answer is postprandial hypertension. Now, the last case for today is of an 83-year-old woman who comes to the office because she has had episodes of dizziness in the past month. Her husband died 1 year back. She has continual unsteadiness that is unchanged by position. There is no new numbness or weakness, and she has not fallen. But the unsteadiness has caused her to turn down invitations, and she has stopped going to her weekly bridge game. She has not been sleeping well, and her past history includes hypertension, osteoarthritis, and glaucoma. On examination, she appears thin, but there is no distress. She has lost 5 pounds since her last visit. The orthostatic vital signs are normal. Visual acuity and hearing are grossly intact. Her strength is good, and sensory examination is normal to pinprick and vibration sense in all the extremities. Reflexes are 2+ throughout. Gait is slow and hesitant, but narrow-based and steady. Now, which of the following is the next best step? Obtain MRI of the cervical spine, perform Dix-Hallpike test, screen for depression, or conduct tilt table test. So the correct answer would be to screen for depression. Functional dizziness refers to a feeling of dizziness, vertigo, or imbalance that has a somatoform or psychogenic origin. It is estimated to account for 8 to 10% of cases of dizziness in a neurootology office. The dizziness is often difficult for the patient to describe, and it might include a sense of floating or imbalance. There are no clinical characteristics that suggest a more definite etiology for the symptoms. Patients with chronic vestibular issues may become depressed. Similarly, patients who are depressed may report dizziness as well as other somatic symptoms that do not have a pathological correlate. In this patient, questioning reveals that she is at high risk of depression. She reports social withdrawal. She has lost weight. She has insomnia, and her husband recently died. Thus, a more formal depression screening would be best for the next diagnostic test. So for today's presentation, I'd like to thank Dr. Nadir Abdulrahman for giving me these opportunities. I took some data or information from PubMed, NIH National Library of Medicine, and the questions were provided to me by Dr. Nadir. And the copyright for today's presentation goes to American Geriatric Society. Thank you.
Thank you so much. This great presentation. Any questions or any comments, any addition?
Yes, Dr. Nader, I have one question.
Go ahead.
Since dizziness is a very vague topic, we see a lot of cases they came with dizziness and they turn to be a posterior circulation syndrome, and they don't have any focal neurological signs to be find in physical examination. So how we differentiate between peripheral and central clinically?
Leepy, you want to go ahead, answer, and then I'll follow?
I think you can describe I think you can explain later.
So yeah, dizziness in older adults usually sometimes the presentation might not be a typical presentation. The reason is as we get older, there are changes in our systems, and sometimes minor changes may contribute together with other changes. So dizziness could be multi-component, and if the patient has, let's say, the circulation problem and any additional component to that problem might lead to the presentation of feeling dizzy and maybe falls or inability to walk the right way, the gait abnormality. So it could be the presentation with the circulation, the problem, but it can be added to other minor things that will show up the problem. And it's I hope I answer your question.
Yeah, thank you.
Thank you. Any other questions? Go ahead, Ahmed.
Hello, everyone. Thank you, Dr. Nader, for this chance. I would like to clarify it more. First of all, you have to clarify the symptoms. It is a vertigo or a dizziness. If it is vertigo, so you go with peripheral causes due to muscle like labyrinthitis and middle ear, inner ear disease or something. If it is a dizziness, go with a posterior circulation. And also, you have to focus on the risk factor. If the patient have atherosclerosis risk factor, so it's most likely we have to suspect a posterior circulation stroke, and also other symptoms of posterior circulation like brainstem, like ataxia, and dysphagia, and other symptoms of posterior circulation.
Excellent. Thank you so much, Dr. Ahmed. And I just want to add, excuse me. So let's say there is a lesion on the posterior circulation. Usually the body will try to accommodate or compensate. But as I mentioned, if there is another factor play, let's say the patient is dehydrated. So both of them, now the body will not compensate enough. Then the symptoms will show up, if that makes sense. Thank you. Any other comments, questions?
Yes, I do have a question.
Yes, go ahead, Dr. Rizal.
Yes. Have you ever been exposed to dizziness or loss of consciousness in elderly patients who have received COVID vaccine? Because I have seen multiple of them, and there's no enough data on that, but it's very common now. So is there anything that you have noticed in your practice?
Thanks for the question. And usually I go to nursing homes, so I don't see that. When I was rounding, I did not. So if I have a clinic, maybe that would be the case. But I don't have outpatient clinic. I go to nursing homes. But this question can be a good research question. Maybe we can investigate that further and see if there is any data that we can pull up and publish. Any other questions or any other comments? If none, thank you again for a great presentation. It's an important topic, and we need to pay attention to the way how to investigate, how to diagnose, and how to treat these problems. And sometimes it's just a matter of the exercise for the benign positional vertigo, for example. So you don't need medications to solve someone's problem. Thank you. We can move on to the next topic.
Thank you, Dr. Nadi. So the next presentation from for screen 1 is Ms. Pathigoda Acharige. I hope I pronounced her name correct. Sorry if I'm wrong. She'll be presenting on the topic, how to select a residency program. Pathigoda, you here?
Hi, thank you, Dr. Leepy, for the great presentation. And okay. I think the screen sharing is disabled.
Hello, can you try again, please?
Okay. Okay. Hi, thank you, Dr. Leepy, for the great presentation. And Dr. Nadi, thank you so much for creating TGRF, because it's a great opportunity for us to present and do research. And because I'm talking about how to navigate the match as an IMG today, it's very important thing for all the IMGs who are trying to get a US residency. I'll start the presentation. Okay. Welcome, future residents. I know all of you are here today. It's going to be resident one day. And this is Sri Lanka. It's my country. That is where I'm from. Right now, I live in USA. So we are all trying to get a residency. So that's why I put this map. So we all, from anywhere in the world, we are going to try to go to US residency. So I'll talk about NRMP match, because that is where we get the residency spot. NRMP means the National Resident Matching Program. So we can apply for all the residency program in US to the common application system, centralized system. And then NRMP is the agency that matches applicant with the residency programs. And it has an algorithm. You can read about it in NRMP website. And there are deadlines there where you can you have to be ready on the submitting rank orders and submitting application and on. Then also the very important thing our application is ERAS application. That is the application that we are going to apply. It has all the information about the future residents. So this application service is conducted by AMC. You can go to that website and find out all the information. There are a ton of information how to navigate through this process. It's very important to know these deadlines. And I have put this year's deadline for the upcoming match. The application season starts 5th of June. So you can start the application and try to work on after this date. And 4th of September is the day that the resident applicants can submit application to programs. And then 25th of September, residency programs started to get the application. So on 2025, 31st of May, ERAS session end for that year. So very important dates you have to remember to make a successful match. And these are the main element of ERAS application. there are some application that you have to fill, then it generates a CV, and you have to put your research experience, clinical experience, and your scores and everything in there. And then you have to write personal statement, and it's very important to tailor personal statement to your chosen specialties, because that is how we can show to the programs that we are committed to these specialties. And then letters of recommendation that you can upload to the ERAS application system, and also the other documents like medical school perform evaluation and ECFMG transcript and other documents if you have mentioned in your CV. And some I know as a international medical graduates that our medical schools sometimes does not create MSPE, but we have to discuss with them and talk to them and to collaborate with them and to create one for us, and that will be advantage on your behalf on the application. And make sure to complete this ahead of time, and also be aware of grammatical mistakes, spelling mistakes, and that will keep you a very competitive candidate. And also this writing a letter of interest to programs that you are planning to apply if you have a particular interest in that program. It could be some a fellowship that you are going to go in future, that program alumni is going to frequently. It could be the location because you live there, you like to go to that program. It's whatever the reason that you have. If you have a genuine reason, it's a good thing to write a letter that you are going to apply there. And then next one is understanding yourself. This is very important because I think because this choosing your specialty and what specialty that you're going to choose depending on your personality, your goals, and your interest, and so many other factors. Why we have to think carefully about this, because sometimes this residency application process for IMGs is very tedious. You have to stay persistent for years and years. And if you choose something you like or you want to work on, you will not get burnout. So that is why it's very important to think about it. Sometimes there are chances that I know in my personal experience, I used to like surgery so much as a subject in medical, as a medical student, but I never knew the lifestyle of a surgeon, or I never thought about it. The subject is very interesting to me, so I was very focused on getting into surgery. But after seeing that lifestyle, I thought, no, I have so many other interests. I want more time to spend time with my family, and I understood that that is not for me. I will probably burn out and leave. And that is why sometimes we feel that it is something our favorite subject, but it's not the favorite career. So also another factor that we have to consider is the competitiveness of the specialty, and some specialties are favorable for IMGs in regard of visa and such factors, because so we have to little bit be flexible and keep another backup plan. So like backup specialty if you are trying for a very competitive one. And also another thing is that some specialties I have seen there, the competitiveness is different in your home country and US. For example, the nephrology is very competitive fellowship in my country because of the demand, and here it is not so competitive as regard to the other specialties. So that is something that you have to think about. So strength and weaknesses. I'll talk about this in a way that because IMG is coming from all over the world, and they have so many great experiences. They are diverse. They have a very strong work ethic, because as I told before that this process is tedious. So it's the person who going through this process become very strong, usually have a strong work ethic. So these are your strengths. You have to show them in your personal statement and your interview. And there are some barriers to IMGs. Some of them learn medicine in different languages. Some of them speak different languages, and this could be a barrier. So you work on that, improve your knowledge about on English, and so sometimes you can use this language barrier as an advantage. For example, if you know a language that is very commonly spoken in the area that you are going to match, that you can tell that I know this language, because in patients like physicians who speak their own language. It makes them comfortable to tell the story. So you can use that into your advantages if you have a language that is spoken in US. And also lack of US clinical experience could be a factor. So you have to find as much as possible experience that you can do. And also sometimes the cultural point, the lack of understanding of cultures could be the patient behaviors, patient lifestyle, could be when you talk to other colleagues and the staff, there will be popular references like football in the huge culture that I could not understand here. So some of those things that you can learn on the way to improve yourself. That's why I see that I put this maps from slate.com that you can see there are some, this is the most commonly spoken language other than English in most states. You can see Spanish. So if you can learn Spanish, or if you already know Spanish, could be an advantage in your application for some programs. And there are other languages other than that. Even it's not a big community, there could be some clusters there who speaks these languages, and you can find in your the programs that you're going to apply how you can apply your language, or you can learn a new language accordingly. And how we research residency programs, how we know the information about the programs. Frida is a great source, and it's from American Medical Association, and then Accreditation Council for Graduate Medical Education has the program list and the accreditation details. So how we know these programs are good or bad, or it's not bad actually, is it suitable for me or suitable for you, or as such. So you have to focus on accreditation and program reputation. You can ask this from the other people who are in the program, maybe in groups or programs, or even your medical school graduates who went to these programs. And also you can look at their curriculums, what kind of clinical experience they are offering, and you can see who the faculty are, that what kind of expertise these professors has, that they might be interested in special research topics or special subjects, or they will be. So if you have the same kind of interest, that you can talk about these things. And then what kind of research the resident in that program has done, and also what happened to them after they graduate, and where they what kind of fellowships they go into. Because there's the program, there are programs are very different from other, because there are some professors that they are heavily involved in some kind of area, for example, nephrology. So there are people from that particular program have very good research experience regarding that area, and then they can go to competitive fellowships or whatever the part that they are going to take after on result of this the faculty expertise. So also for example, that my husband is a fellow, gastroenterology fellow, and he was at a program that there's nobody going to GI gastroenterology, because it is not heavily on that, so people didn't do much research or do much work on gastroenterology, so it's very, very rare to go into that specialty. So you have to put it, if you are very enthusiastic about that subject, so find something, a program that you want to go into in future, to this, thinking about future too. And then location of the residency program. It is important because there are some states that, for example, New York, it has largest number of non-US IMGs, because they have lots of program with the visa sponsorship. And then you can find, when you research program through a FRIDA database, you can find New York programs, and this where the number of residents, there are more residence programs with non-US IMGs, and where they go, or what states the most of them are. So according to that, you can find out the chances of matching into these status are high. So if you live already in USA, so you have to find the best possible places that you can go. So you can work, if it is possible for you to change your location, and do so. And the importance of location is, another factor is the cost of living. If you're an IMG with a family, and if you are the only one who works, and it will be difficult to live in high cost areas like big cities with a one-person salary, because residency salary is not very high. And then also you have to stay with your family, and sometimes some people like city life, some people like suburban life. So you can find a balance and what kind of program that you want to go. And then also, as I mentioned, visa sponsorship by programs. It is very important to consider these factors and find the location that you decide to go. Also, next one, finding IMG-friendly programs. And FRIDA is a good source, as I mentioned before, to find where IMG matches most. Like some programs, you can find the percentage of, you can adjust this the filters, 100% IMG programs, 50% IMG programs, or whatever the desired number that you are looking for. And also you can find, you can go to their program website and find how many are from, maybe you can find, because a program website shows the pictures of IMG, the residents with their profiles, where they are from, what university they graduated from. Most of the programs has websites like that. So you can find those find whether there are any alumni from your university or your country in these programs, and it will be beneficial in the future. And there are match outcome data for IMG published by NRMP every year. So go to that, take that, download that book, and go through all the charts and diagrams that you can find out your what specialties are more IMG favorable, and how much marks that needed to go to that specialty, what is the average matching marks that they have matched in the past. So you can see that I have put one picture here. It's a diagram that how now non-US IMG match into specialties according to their step 2 scores. I'm sorry, it's missing here, step 2 scores. Okay, now you can see this blue color bars, they are the match ones, and the light green one, the green ones, they're the not match ones. So you can see with all the specialties that mentioned here, what scores that you have to go into these specialties in average. And also you can find information about your clinical experience that required for each program, and USMLE scores, cutoffs, and as well. So the matching into a residency is very, you need to do a lot of work. So you have to stand out from the crowd, and they have to see you apart from the crowd. I have put a quote here: "Be so good they can't ignore you." To how to strengthen your application. The first one is use clinical. Now you have done the part of USMLE exams. So next one is the use clinical experience. You can get it even before the exams. So you have to get as much as you can and enhance your clinical skills, and also get familiarized with the US healthcare system. And it will show the programs that you are adaptable to the US healthcare system. You can start right away when you start residency. And then next one is research experience. It's very good a chance to show how interested you are in this specialty, and also your skills and presentation and participation in research projects. And this fellowship program is an amazing program that provide you that. And next, strong USMLE scores. Go for the highest possible scores you can, because it is the starting step that you can make a difference. Because if you, before doing anything else, that's why it's very important to focus your full attention to USMLE exams without any distractions at all. Because this shows that your medical knowledge and foundation, this is like the first step and first step to the road ahead. So the next one is personal statement. This is where you can show that who you are. So create a beautiful personal statement and get help as much as you can from your English teachers, maybe your mentors in medical school. Ask your peers to read it and get the comments of there. And very important, if you can tailor it to each program, it is amazing, because then you can highlight why you are a perfect candidate or perfect fit for this program. And also strong letters of recommendation, because if it is from a US faculty, it is very, because usually US faculty letters are more valued. But if you have home country recommendation letters, if you from a professor or doctor that you know very well and you know your work, it's good too, because it will show that what you mention in personal statement, it will provide an evidence, because you are this person, and this other the people who work with you recommend you as well. So make sure you have get the letters of recommendation to your advantage. And then networking works miracles, and building connections can significantly benefit your application as an IMG. There are many ways to do this, because networking could be very intimidating. Try to attend residency conferences and workshops. This is very expensive thing to go in person, I know, but try to get in online ones or virtual ones, or even if you live in US, try to go there as in a convenience way, and then connect with program directors and residents online. This is a good, I mean, there are so many platforms, like the residency programs has web page, the social media accounts, so you can go there and see what they are doing, what they're posting, or maybe you can be with that community and talk and share your ideas. And also online forums and professional social media platform like Proximity, the Student Doctor Network, and you can connect with people and ask your questions and ask your doubts, and you can discuss your research or your interests. And then mentorship. Mentorship is a very good thing because mentors can make a big difference in your career. So find a mentor who can vouch for you, who can guide you in your desired specialty. And also reach out to alumni from your medical school. This is a great place to start the networking process, because these are people who came from your background. So it will be easier for you to approach them. So it will make a big difference in the matching process. And I put this book rejection proof because sometimes you write people to talk to people, you definitely get rejections. Be aware of that and don't get discouraged by that. And next one is interview. Master in interview. This practice is the key to this. Now you have done all your work and you have sent your application. Now it's time. Then now you got the interviews, so it's time to perform. The research each program thoroughly before you go, and anticipate interview questions and practice and practice and practice. And practice with a friend, practice with the family, practice with your mentor, and whatever the possible way that you can, ask very meaningful questions. Don't ask the same old questions you got from somewhere. You can tailor it to the program, specific questions that in that way you can make a memorable impression in the interviewer. So be prepared to discuss your strength as an IMG, and highlight your cultural background, adaptability, and global medical practice as a IMG. So I put this Cinderella picture because Cinderella went to this ball and she was kind to everyone from the start. And then she made a lasting impression. Then out of all the candidates, she was chosen. So that is what I want. I put it there because make an impression, be kind to everyone, show who you are, show your true self, and you will get that. And these are the resources for IMG success. You can find ton of information from the websites. Association of American Medical Colleges, that's where the ERAS application is from, and American Medical Association has so much information for IMGs and stories, blog posts, and some articles, and about observerships opportunities as such. And also ECFMG has lots of information too, and residency program website provide lots of information about even what kind of faculty they are, the life of the residency, and utilize these resources to learn more about programs. And also my program forums and communities for IMGs that you can ask questions, your doubts, and you can find out what kind of programs, and you can read successful stories in the IMGs who have successfully navigated the match process. And also YouTube is a great platform. There are faculty YouTube channels that residency programs sometimes give their lectures or some grand rounds in their channels. And there are IMGs who match into programs and who talk about their experiences and gain as much as information through these resources. Now your journey, your residency journey. I believe your journey started the day you took your step exams, and then all the things you do for the match. And then the match process is tedious, but go through that. And then if you did match and you have to go through SOAP. And there was a great presentation by Dr. Umbada because of that, I did not include SOAP in my presentation. So if you end up unmatched, then review and correct errors and ask for guidance and repeat the process and take time. I know it's take time and money and much more, but it is worth. The road is long, but you will reach to beautiful destinations. And I share IMG success stories with stories. This is something very personal to me. And this is my husband, Leepy. He matched into internal medicine in 2018. So this picture shows his mentor, who was chief resident at the time of Dilip's application, and then he knew her from his medical college. They were together work as a Catholic society, so they knew a little, not a lot. But after he did USMLE exams, he reached out to her and told her that I'm interested in going to this program, and then she was very supportive. And even though they didn't have a great connection when they were in medical college, and then later they developed a great friendship, and still they are we are family friends. And then he went to GI gastroenterology, even though his program was not supportive of gastroenterology. At that time, he matched there, and he was persistent about going to GI, even though many people discourage because it's very hard to get into. There are any alumni who went there. So the thing that happened, they created a gastroenterology program inside the health system. So he's the first one to match there. So this kind of opportunity comes up. So don't give up. And these are the stories that there's some of them of my personal stories. This first story is from a doctor from my country. She's the #1 rank in final examination in Sri Lanka. So we have a ranking system for all the medical graduates. So she was #1. So she was the best performance. She gave the best performance for her year in Sri Lanka, but she went unmatched despite of great scores, despite of her excellent profile. So she next time she strive for new programs, and where she got selected for the first batch. She's now assistant professor in Emory University, and after doing fellowships, and it has this kind of some people with excellent profiles can get unmatched. That's what I want to show. But don't give up. Change your perspective. Change your strategy and aim again. And there's another friend of mine who had internal medicine residency training at home country, and then end up having low scores for step 1, and it was very difficult for her being an old graduate with low scores, even with low funds, because sometimes you have to spend money for some observerships, but she kept trying and asked her PCP to give an opportunity for observerships, and from there she got other opportunities, like went to York University and found some research experiences. Through these connections, he matched into family medicine program, and now she's a successful doctor. And this another one I found, this is a famous Dr. Mansouri. He's a famous among IMGs. Probably heard about his story of matching after 7 years, and he was the only applicant to present that day on the interview day, because despite of the heavy weather condition, and they were impressed and took him, and then he went for so many other adventures, and now he's a Ivy League assistant professor in Ivy League program. So he always put this kind of motivational success stories in his social media platforms. So anybody can do that, and then you can find a story that matches to your profile, because there are lots of success stories you can find for your match. And the persistence is the key to success full match in to residency as an IMG. So if you are persistent enough, you can do it. Good luck, everyone. Thank you so much. Do you have any questions?
Actually, I don't have a question, but there's a thing that I've heard of recently, and I think many of us didn't know it before. It's the double board certification, like to become double board certified. Since I'm interested in family medicine, so in family medicine, you can do like internal medicine and family medicine double board certification during residency, which I find very interesting.
Oh, okay. I really don't know about this much. Dr. Nadir, do you have any thoughts about this?
I haven't heard about this. I know some folks like they start one in one program and then they switch. I have a friend of mine who finished family medicine and then joined internal medicine. So he went to cardiology afterwards. So it depends. But this is the first time I see double between both of them, family and unless you do that way, I have no idea. Thank you. Go ahead, Dr. Rahma.
Hello, everybody. So I have a question regarding the application to ERS and to the match. Is it safe to apply if you didn't have your SFMG certificate yet, like you didn't finish one of the steps or the OET exam, or it would be like waste of time and money? Hello?
Sure. Do you have any answer for that, or maybe one of the seniors, maybe they can elaborate?
Hello, good evening. Regarding the last question, I believe you said if you can apply to ERAS when the ECMG certificate is still not issued. Is that your question?
Yeah, like I haven't I didn't take my OET exam yet, so I didn't. I will
Yes.
later
So
in. Yeah.
yes, please go ahead. Yes.
So I think I won't get my SFMG certificate sooner. So
Yes. So it's fine. You just need your step 1 and step 2, and it has to be like you have the transitional certificate in the ERAS. They don't ask for the OET. They don't ask for the pathway completion. So it will not be necessary for you to have the ECFMG physically with you, the certificate, when you apply for the ERAS.
okay,
I hope
thank you.
that. Thank you.
Yeah, I can add on that. Do you hear me? Yeah. Hello?
Hello, Dr. Amna, go ahead.
Yeah, the OET or the certificate is important for rank list for NRMB. So you have to make sure you did this for January to be able to make your order list. That was important of it.
Yeah, I think, yeah, the programs needs to know that, I think, or the NRMBP, they require that you have the certificate, I think. Good question. Abu Qasim, please go ahead.
Hello, how
Thank
are
you
you
for
doing?
this. Okay.
I had a question about ERAS application too, concerning geographical preference. after a bit of search, I found out that you can have three geographical preferences, and I wanted to ask, should you keep it to one, or having three will not make any effect on your applications and chance of interview?
Can you please repeat the question?
Concerning geographical preference on the ERAS application, from what I've found on the internet, that you have three preferences, that you can, up to three preferences that you can put down. I wanted to know, does it affect your application on chances of interview if you put all three instead of just putting one?
I don't know the answer for this question. I'm sorry, but anybody who knows this answer? Dr. Madini says geographic list is important to the program. It's not affect your application.
Okay, go ahead, Dr. Mohammed, followed by Dr. Lema.
Yes, hello, Dr. Lini. Good evening, and Dr. Matterton. Thank you so much for the presentation. I got a question regarding whether if you had a chance, like to do a USCE or like to do step 3, like which one would you rather choose? Like which one is going to be more impactful in your CV if you had to choose one? I was just wondering.
I think the US clinical experience will be much valuable, but depending on the visa type, that if you want to get H1B, then you go through the step 3, and also some programs they require US clinical experience, so that you have to find out that where or what specialty that you are going to apply and what visa type, and I think it's depend on that, which one that you have to choose from. Dr. Nadir, do you have any other idea about that?
I think I agree with you. I'm not sure about the other seniors. Anyone with other answers?
Yes, regarding the US clinic experience or the step 3, I believe they're both important, but now when you're approaching the application process and you need to have some experience in the US, you need some maybe letter of recommendation from doctors. So if you have the US clinic experience, even for the least amount of time that you can apply for, it will be helpful. And once you finish your interviews, if you can apply and finish your step 3 before joining your residency program, hopefully, it will also be beneficial for you. So that's what I think. But it will have to also be from your personal choice regarding your situation. Thank you.
All right, thank you so much.
Thank you all. Thank you, Thelini, for good presentation. Dr. Lema, go ahead. You are muted, Dr. Lema or Lima.
Oh, hi. Sorry about that. I was having some technical issues with my computer. And my comment on this one is it depends on the program preference and our basically year of graduation too. If an applicant is year of graduation of below 5 years, so going for clinical experience will help them a lot, I believe, because most of the programs are like that on clinical experience, but some programs are not like concerned on clinical experience and consider the overall application of the applicant. So in that case, especially if you're having all the year of graduation, more than 5 years, going for step 3 will benefit you as well. But if you don't have time and running to decide between the two, I think still clinical experience is better because you will get at least a few weeks of clinical experience. You may need more time to prepare for step 3, though that's the case for that one. But for about the geographic preference, this year it's changing, I think. For internal medicine, the geographic preference is going to be probably 5 locations, but programs are like in line of geographic preference and signaling. So applying those will increase your chance of matching, I believe, because when you see the data that are coming out this year, so they're focusing to screen patient applicants for interviews and even for ranking. They're considering their preference on geographic preference or signaling. So it's very important, I believe, on the application. So yeah, that's my point on that. Thank you.
Thank you so much. Dr. Mohammed, go ahead.
Okay, I just wanted to inquire about how much of a problem is the presence of a clinical gap, like for a really good reason, or at least if you left your country and you don't have a license in another country, does that affect your application? You're practicing in your country and then you left for another country and you don't have a license to practice, so there's a clinical gap. Does that affect your application much?
So most of the time they want you to have clinical experience. They prefer the US clinical experience over overseas clinical experience. So if you are in this situation where you practice in one country and for some reason you could not continue, but now you are here, my advice or suggestion is to start finding any clinical experience here so that you can fill some of the gaps. As long as you are showing that you are improving your situation and seeking knowledge, seeking skills, training, they will consider that. Thank you.
Thank you, everyone. I think we are done with the questions. So the next presenter for today is Dr. Abdulalim. He will be presenting on Zoom presentations, how to use Zoom for presentations. Thank you.
Hello, everyone. Is my voice clear or?
Yes.
Hello, everyone, and welcome in our module in using Zoom whiteboarding. Before I start, I would like to introduce myself. I'm Abdulalim Hag Ali, MBBS, fourth year medical student at University of Science and Technology. I also would like to thank Dr. Nadir for this great opportunity, and I also want to thank my supervisor, Dr. Leepy Paudel. Our module today is about whiteboarding in Zoom. We have a lot of methods to do that. We have 5 methods to do whiteboarding. Let's go step by step to know all of them. First method is using Zoom screen sharing plus computer only, and also can be mobile phone instead of computer. The first step is to open the software you want to use for whiteboarding. for example, PowerPoint, Microsoft, etc. The second step, start a Zoom session on your computer or your mobile phone. Set it recorded if you want to record the Zoom meeting. Step 3, select the sharing screen. You will find it below in the screen. Share the Zoom at the bottom of the Zoom session. Second step, to share your screen in different apps, select share content, and then open the whiteboarding app. Fourth step, if you're using Zoom whiteboard, you are all set. If you're using another app, you can go and choose another app. Select software application you use for whiteboarding. Click option share. The 5th step to stop sharing and back to the Zoom again. We will see this method now. I have one of whiteboarding apps. It's here. Now I can use it. This is method 1. Method 2, by using Zoom screen sharing using the computer plus iPad. You can use your iPad as external device to project content into Zoom meeting on your laptop or your computer. This approach allow for using whiteboarding app available only in the iPad. The method, first step, start the Zoom session from computer. Second step, open the Zoom app in your iPad. Third, join an internet meeting ID from your computer, and then join with your iPad. Disable camera and mute your mic from iPad in the Zoom, and tap share content whiteboarding. To use the Zoom whiteboarding, tap share content and select the application you want to share if you're using another whiteboarding app. This is for whom using iPad and computer. Method 3, Zoom screen share plus iPad using share Zoom. This is similar to the method 3, but the difference, you just use the website, the share website, and then just enter the meeting, and it's become your iPad will become a whiteboard. This method is similar to method 2, except you're using a share.zoom and .us website in iPad browser instead of zooming up into the iPad. It's the same, but you just use the share.zoom.us. The difference, just you will enter the ID of the meeting, and then your iPad will become the whiteboard. We are going to the method 4, which we use Zoom plus iPad plus a third-party app using a cable. It's also similar to the method 3, but you're using hardware with cable. The first method is connect your iPad to the computer using to the host Zoom via USB Lightning cable. Start the Zoom session on your computer. Set it, record it if you want to record it. Open whiteboard app and select share iPad or iPhone via cable, and it's work as a whiteboard. This is a suggested app for whiteboarding in iPad. Adobe Draw. It's all free. Adobe Draw and Autodesk Sketchbook. Method 5, it's Zoom plus overhead camera. The step, set up your workplace when your pen and paper whiteboard. Connect an external webcam to your computer and place it above your whiteboard workplace. For example, you can sit in on top the stack book or shelf nearby, and there is a video explaining that and give you example. The third step, start your Zoom session. Set it to record if you want to record. Select share screen, then choose content from the second camera. The external webcam should now be displayed for student. To stop sharing, select stop sharing for the top menu. And thank you. Any question?
Thank you so much for great presentation. Any questions or any comment?
Thank you for the presentation. I was just wondering if he could share the link to the website he was using to explain. Thank you. Dr. Abdulalim.
Okay, I will send it in chat box now.
If no more questions, we can move on to the next item in the agenda. So we have the organizational skills. Is any presenter there? Dr. Leepy? I think there was one question about the residency earlier. One of the fellows raised his hand. Hello, Dr. Ahmed, go ahead.
Hello, Dr. Nadir. How are you? How are you, everyone? I wonder if I graduated in 2022, and I have step 1 and step 2. Like recently, I take the exam. I'm waiting for the result. I'm wondering if I should apply to the next match or wait or wait to build my CV because the surgery is highly competitive. So my question is, should I apply the next March or wait until I have a good CV? Thank you.
This is a great question, and I think it depends on how your past experience, along with if you have good experience, clinical experience here in the US, your connections, and your application itself, your competitiveness, the scores, and if you have any research or other activities that can help. If you don't have enough, my suggestion is to wait for next year. In the meantime, you try to make connections with surgeons and try to be in some of the programs hands-on, see if you can work with them in research projects, even with animals and so forth, so that you can build your CV and then next year you can apply. Thank you.
Thank you, Dr. Nader.
Dr. Mohammed, go ahead, followed by Dr. Barbage Alam.
Okay, okay, I have a very similar question to the past one. The only difference is I'm a bit of an older graduate. I graduated in 2019. I have both steps. I've got a 260 plus in step 2, but my problem is I have no clinical experience and I don't think I have enough time this year to get the clinical experience. Should I apply or? And I have very little research experience.
Again, because it's very competitive, my suggestion is to wait. And then
internal medicine, like not surgery.
Oh, internal medicine. Do you have clinical experience here in the US or?
No, no, I don't.
Do you have overseas clinical
Yes.
experience?
Yes, but yeah, but not on a residency program.
Yeah, it's half and half, I'd say. So 50-50. But my suggestion is to wait and make a very good application and build your resume so that you will be competitive. Unless there is any input from the seniors here. Go ahead, Dr. Carpet Alan. Sorry, I mispronounced your name. Go ahead.
Hello, Dr. Nader. How are you?
Good,
So my question is that how much important is letter of interest to get interview, and what is the best time to send a letter of interest to program?
Anyone of the seniors want to answer, and then I will follow.
Yes, that's a very good question. So letter of interest were actually very helpful even in the last season. So from my experience, I started sending the letter of interest, I think about 1 or 2 weeks after the application was sent. So, and then there's also a second round of letter of interest that you should send, and that's after receiving the interview, the invitation, and also after the invitation. And then finally would be around the letter of the list of residency programs. Just before you send yours, just send a final letter of interest to like email to the programs. So I would say like 2 to 3 rounds will be very helpful. So starting from the first or second week after the application is sent. That's what I would suggest, but I would like someone else to also suggest. Thank you.
I agree with Dr. Mafaz. Thank you for the question and for the great answer. So I think the purpose of the letter is to highlight in a short, very concise manner to let them know that you are very good, you are distinguished from the other applicants. Sometimes that means if you have good publications, or if you have the visa, if you have step 3, something that the program will put in mind that they will consider you over other applicants, if that makes sense. Thank you. Go ahead, Dr. Rahma.
So I have a question regarding asking doctors and physicians how to physicians to go to do US clinical experience with them. So I meet a lot of physicians here. I live in New York City, so they offer their help, but but they tell me wait until you finish step 2. I recently took step 2, so should they contact the clinics or the hospital where they work? How to ask them for clinical experience? Like, what's the right way to start? Because like I know where they work, but like I don't have their personal number. But when I met them, they offered to help. How to approach that? Thank you.
So the best option is to look at the hospitals that they work at. Most of the time you will have the web page for that hospital or the clinics, and then you will find their contact info. It's not going to be a direct contact info. You're not going to get their personal cell phone, for example, but you will have the hospital phone number, for example, or the clinic phone number. What you can do is you can contact them, call them, and see if you can leave a message for that doctor to call you back. So you will leave your name, your cell phone, and then when they have a minute, they will call you back, most likely. Then you can explain to them that I already cleared step 2 and I'm ready for the clinical experience whenever you are at the hospital or at the clinic. So I think that's the best approach. If any input from the seniors, that would be great. Thank you. Sometimes you might have access to their email address in the web page for the hospital or the clinic. So if you are successful in obtaining their email address, that might be another way of reaching out to them. Dr. Leepy, any other presenters, or we are done with?
Okay, thank you, Dr. Abdulalim. So the last presenter for today is Maad Nasor. So we'll be presenting on teamwork.
Thanks.
Hi, hello everyone. Hello everyone, can you hear my voice?
Yeah, you can hear me.
I think I have a problem in sharing my screen. Only the host can share in this meeting.
Can you try again, please?
Okay. Now you can see my screen.
Yes.
Okay. Hi everyone. My name is Maad Ahmed. I studied in University of Medical Science and Technology in Khartoum, Sudan. I'm a surgical resident in my home country, but now working as a general practitioner in United Arab Emirates. I'm done with my step 1, step 2, and I'm planning to apply for the upcoming match, inshallah. So please, everyone, keep me in your prayers. I will present to you today about teamwork. Let's start with a great sentence said by Bill Bethel. A successful team is a group of many hands but one mind. And I think this is what's beautiful and what's hard about teamwork at the same time. The presentation would be a story, The Tortoise and the Hare. I believe everyone heard about this story when we were kids, but today we will see it from another perspective. And please keep in your mind, this is not a bedtime story, so I don't want anyone to sleep during my presentation. I want all of you to focus and extract the manner behind this presentation so we can apply it in our groups, inshallah. So once upon a time, a tortoise and a hare had an argument about who was faster. I am the fastest runner. That's not true. The fastest runner is me. So they decided to settle an argument with a race. They agreed on a route and started on the race. Okay, let's have a race. Fine. Then the hare shot ahead and brisky for some time. Then seeing that he was far ahead for the tortoise, he thought he had sat under a tree for some time and relaxed before continuing the race. Poor guy, even if I take him out, he couldn't catch up with me. He sat under the tree and soon fell asleep. The tortoise plodding and overtook him and soon finished the race, emerging as undisputed champ. The hare woke up and realized that he had lost the race. The moral of the story is that slow and steady wins the race. This is a version of the story that we have all grown up with. But the story continues. The hare was disappointed at losing the race, and he did some soul searching. He realized that he had lost the race only because he had been overconfident, careless, and lax. If he had not taken things for granted, there is no way the tortoise could have beaten him. He asked himself, why did I lose the race? So he had challenged the tortoise to another race. The tortoise agreed. Can we have another race? Okay. This time, the hare went all out and ran without stopping from start to finish. He won by several miles. The moral of the story here, fast and consistent will always beat the slow and steady. If you have 2 people in your organization, one is slow, methodical, and reliable, and the other fast and still reliable at what he does, the fast and reliable sharp would consistently climb the organization ladder faster than the slow methodical sharp. It's good to be slow and steady, but of course, it's better to be fast and reliable. But the story doesn't end here. So the tortoise did some thinking this time and realized that there's no way he can beat the hare in a race the way it was currently formatted. He think, how can I win the hare? He thought for a while and then challenged the hare to another race, but on a slightly different route. The hare agreed. Can we have another race? This time we will go through a different route. Sure. They started off in keeping with his self-made commitment to be consistently fast. The hare took off and ran at top speed until he came to a broad river. The finishing line was a couple of kilometers on the other side of the river. The hare sat there wondering what to do. In the meantime, the tortoise tumbling along, go into the river, swam to the opposite bank, continued walking, and finished the race. The moral of the story, first identify your core competency and then change the playing field to suit your core competency. In an organization or a group, if you are a good speaker, make sure you create opportunities to give presentation that enable the senior management to notice you. If you're strength in analysis, make sure you do some sort of research, make a report, and send it upstairs. Working to your strength will not only get you noticed, but will also create opportunities for growth and advancement. The story still hasn't ended. So the hare and the tortoise by this time had become pretty good friends, and they did some thinking together. Both realized that the last race could have been run much better. Hi, Betty. How about doing our last race again? Great. I think we could do it much better if we two help each other. So they decided to do the last race again, but to run as a team this time. They started off, and this time the hare carried the tortoise till the riverbank. There the tortoise took over and swam across with the hare on its back. On the opposite bank, the hare again carried the tortoise, and they reached the finishing line together. They both felt a greater sense of satisfaction than they had felt earlier. So the moral of the story, it's good to be individually brilliant and to have a strong core competences, but unless you are able to work in a team and harness each other's core competences, you will always perform below par, because there will always be situations at which you will do poorly and someone else does well. Teamwork is mainly about situational leadership, letting the person with the relevant core competency for a situation take leadership. There are more lessons to be learned from this story. Note that neither the hare nor the tortoise gave up after failure. The hare decided to work harder and put in more effort after his failure. The tortoise changed his strategy because he was already working as hard as he could. In life, when faced with failure, sometimes it's appropriate to work harder and put in more effort. Sometimes it's appropriate to change a strategy and try something different. And sometimes it's appropriate to do both of them. The hare and tortoise also learn another vital lesson. When we stop competing against a rival and instead start competing against the situation, we perform far better. To sum up, the story of the hare and tortoise teach us many things. Never give up when faced with failure. Fast and consistent will always beat slow and steady. Work to your competences, compete against the situation, not against a rival. Pooling resources and working as a team will always beat individual performers. I think we reached the end of our presentation. If anyone have a question, you can go ahead. Thank you very much for your listening.
Thank you so much, Dr. Maad, for a great story and presentation. Thanks. Any comments or any questions? If not, we can go to the updates. Any projects, new ideas or updates?
Hello.
Hello, go ahead, Dr. Ahmed.
السلام عليكم.
عليكم السلام. Go ahead.
شكرا جزيلا لكل thank you for the all presenters. the last presenter يعني ذكرتنا بذكريات الطفولة وأيام الصبا. أتكلم بالعربي شوية يا نادر.
Go ahead. I will try.
ذكريات الطفولة وأيام الصبا قالوا تظل عالقة بقلب الإنسان كواحة مخضرة يلجأ إليها الإنسان كلما تجهمت الحياة في وجهه. بتذكرنا بقصيدة أبي القاسم الشاب في الوادي السعيد كم من عهود عزبة في عدوة الوادي النضير فضية الأزهار مذهبة الأصائل والبكور. Thank you. حقيقة it is nice presentation and great lessons for those who apply for the residency. And the thing I wanna, because I have been there, done that, the most important thing is overall, this process is complicated, but very doable. The most important thing is you have to start. You can apply at any time, but everything you add, it will add to your success at the end. I'm not mentioning something new right now, but I'm just reiterate and remind you of being consistent all the time and have your networking. Your previous experiences matters a lot. And the other thing is that if we talk specifically, have your letters of recommendation from US. That will help. And sometimes what matters is the way you present yourself during the interview. That is very important, and that could add more than 50% to your being accepted in the program. I will just tell you the story. My story with matching was pre-match. And also you have to read about the program you are applying. For example, the program I have applied to, like there is a lot of patients with sickle cell anemia. And, you know, for sure you will see one of the panel is hematologist, for example. And sure enough, during the interview, there was. And I was asked about the case. So I have seen many cases. I have done my housemanship in Sudan. It was rotational, very interesting. I did all like OBGYN, general surgery, ENT, general internal medicine at that time in Khartoum. It was very interesting. So the case, sorry, yeah, I'm sorry about that. So the story as the case I chose to present or just to tell them a little bit about it was management of a sickle cell case. And when we came to discuss the management, and I specifically chose the word hydration. And I elaborate on that. So when you choose that, that means hydration in a sickle cell crisis. That means you are talking about the pathophysiology, and you can be evaluated at the spot. So I feel that presenting a case talking about the management, putting in mind that you are concentrating about the pathophysiology of the disease, that could help. So such kind of approach is helping. So you put a lot of effort on your application, the connection, letter of recommendations, but at the same time, that interview matters a lot. Okay, this is one thing. The other thing is that after the interview, because there was a question about the letter of showing that to show interest in the program. So when they know you, the letter of the letter of interest will show like it will have a more impact because you are already know about the program. So you are showing your interest. So it will be kind of having a more impact than when you send it earlier. This is just from my experience. And remember, once again, it is a process. All you have done before, you are just putting it on your application, and also you are presenting it at the same time. Thank you. Back to you, Nader.
Thank you so much for your input, Dr. Ahmed. This is great, and I hope this will help some of the fellows in this program. Thank you so much.
Thank you.
Any other comments, any other questions, updates, suggestions before we end the meeting? Go ahead, Dr. Anna.
Assalamu alaikum.
Alaikum salam. Go ahead.
I was actually trying to come up with ideas for the past week, and I was thinking of doing something related to the frailty assessment in regards to elderly patients with lung disease undergoing radiotherapy. So I presented the idea to my group leader, but I'm still looking at literature review.
Sounds great. So if you have any other questions, we will be happy to help. Usually the seniors will lead you as far as how to do all the methods. And the next step will be like you create a team of fellows who are interested in the same topic. And then you will be the leader for that project. You will divide the task between the members of the team, and hopefully you will finish the project and submit and get accepted. So we are here to help.
Thank you. Thank you.
Thank you for sharing. Any other questions, comments? If not, I'd like to thank you, Dr. Ahmed, for joining and for helping us with this program. Dr. Ahmed and I mostly working with you guys on establishing this program and continuing together. So thank you, Dr. Ahmed. I'd like to thank the team leader, Dr. Leepy, and your presenters from today's presentation. You did a great job. Thank you. I'd like to thank all the attendees from today's and those who will come and watch the recording later. Thank you, everyone, and I wish you all, I wish everyone happy day and have a nice evening wherever you are. Thank you. You can reach us by email or send us a text message or call us. We'll be happy to answer and help you. Thank you all. Assalamu alaikum.
Thank you, Dr. Nader.
Thank you, Dr. Nader. Thank you, everyone.
Thank you, Dr. Nader.
Thank you.
السلام عليكم ورحمة الله.